I request Dr. Santosh Kumar to kindly come and make his presentation, please.
Good morning. I think the task given to me this morning is to discuss about the outcomes that we've analyzed from a large cohort. This included Coimbatore Medical College, led by Dr. Mangekarasi Madam, and the CMC Vellore team. So we have evaluated the performance of low volume plasma exchange both from a public and private sector hospital. Next slide, please. So I think my speakers ahead of me have already dealt in detail about the evidence that we have so far, showing that low volume plasma exchange improves transplant-free survival. However, the studies that have been done and shown so far are from a single center and the numbers are small. So what we hope to do is evaluate the impact of plasma exchange treated patients with rodenticidal hepatotoxicity from two large cohort from Coimbatore and Vellore. Next slide, please. So it's a retrospective study. As mentioned earlier, it is from Coimbatore and Vellore, and we collected data from hospital records from admission to discharge. The timelines of data collection from Vellore, it was between 2017 to 2024, and from Coimbatore it was between 2022 to 2024. And inclusion were patients with rodenticidal hepatotoxicity who underwent PLEX, and patients excluded had other treatments or incomplete records. Next slide. I think Vijay had dealt with this definitions and measurement of patient severity in detail. I'll just run it through. So uncomplicated hepatitis is a patient who's got hepatic dysfunction, that is LFT abnormality. Acute liver injury is when there is INR elevation more than 1.5 on top of that. Acute liver failure is when the same patient develops encephalopathy. And King's College non-paracetamol criteria is used to stratify who is a high-risk patient and who will require transplant. And I think Vijay also showed about the Kochi criteria where MELD is more than 36 or INR more than 6 and with hepatic encephalopathy, which is a condition with absolute fatality. Next slide. So I'm just showing a different version of the protocol that we are using. This was published in Journal of Clinical Experimental Hepatology. So we prefer to use low volume plasma exchange. We prefer to use femoral line. We prefer to use low dose steroids. We prefer to use centrifugal plasma exchange technique. And we, in our center, use prophylactic antibiotics during plasma exchange. And as mentioned earlier, we avoid sedatives and prevent unnecessary transfusions for the sake of line insertion. Next slide. I mean, this content has been shown again and again. I just want to briefly mention into the contraindications because hemodynamic instability and active sepsis are contraindications as per the Thai NHM for rodenticidal hepatotoxicity when we are considering plasma exchange. Next slide. So going on to the results, just to give an idea, there were about 360 patients from both centers. So Coimbatore had 230 and Vellore had 130. And just to highlight, these were young patients, median age was 28 years and majority were men. Just to say that these people were not having underlying psychiatric illness or past deliberate self-harm. So these were mostly impulsive act. Majority did not have any underlying psychiatric illness or past deliberate self-harm. And in this study cohort, 98% had ingested yellow phosphorus. Next slide. Next. So to assess their severity parameters before PLEX, as we could see, the median bilirubin was 4, which is elevated. The INR was 2.36, again elevated. The creatinine was in the normal range, and MELD, just to give an idea, normal MELD will be between 5 to 6. So here the MELD median is 22, and the interquartile range is also quite high, 13 to 31. Next slide. So while we try to categorize them as different syndromes, majority were acute liver injury or acute liver failure, and a small fraction, less than 20%, were uncomplicated hepatitis. and 15% of them satisfied King's College criteria prior to Plex, and 20% of them satisfied Kochi criteria. So this King's College and Kochi criteria meant that these patients had no possibility of survival when they were treated with plasma exchange. Next slide, please. Going through what was the type of plasma exchange and the steroid treatment given during in between these two centers. So majority 82% had centrifugal type of plasma exchange. Steroids were given in 71.4% of patients, and prednisolone was the preferred steroid in Vellore and dexamethasone was the preferred steroid in Coimbatore. Median sessions were 3, so most patients received 1 to 4, but the median plasma exchange session was 3. And the volume of exchange per session was 1.6 liters. The bottom of the slide, just to highlight, to show patients who came late, that is when Plex was initiated late, that is because they are already gone on to ALF. So when patients presented early, that is between a median of 4 days, they were mostly in acute liver injury or uncomplicated hepatitis. So again, to highlight that patients from this spoke have to reach the hub early rather than late. And majority of the patients after plasma exchange showed a good decline, a median decline of 22.7% in their MELD. And Vijay already had said, if the MELD declined by more than 20%, there is a great chance of survival. Next slide. So going on to the outcome, which is the focus, among the 360 patients, we had 239 patients surviving, which meant about 67.3% survival, which is a good outcome. And among various severity categories, we could see when the pre-Plex syndrome was acute liver injury, close to 80% of patients survived. And in the pre-Plex syndrome of acute liver failure, we had close to 50% survival. Among patients who fulfilled Kochi criteria, where we know the fatality is 100%, we had 40%, nearly 40% survival. And in King's College criteria satisfying patients, we had close to 31% survival. Next slide. Next. So going back to the Thai contraindications, we noted among patients who had Thai contraindications, the outcome was poor compared to patients who did not have Thai contraindications. So the bottom two, we have tried to exclude patients who had Thai contraindications, and then we saw the Kochi criteria fulfilling patients from 40%, their survival improved to 50%, and the King's College criteria satisfying patients from 30%, their survival improved to 42%. So if you choose the right patient, that is a patient without hypotension or active sepsis, then the survival in these particular subgroup is very good. Next slide. So this is a Sankey diagram just to show the patient flow. As we could see, while the patient was admitted, there could be uncomplicated hepatitis, but as their course in the hospital, some became from uncomplicated hepatitis to acute liver injury. Similarly, some acute liver injury progressed to acute liver failure. What we found is the worst syndrome, if it was uncomplicated hepatitis, obviously majority do not die. In acute liver injury also, we had a significant amount of patients going on to survive. And in acute liver failure, close to 50% of patients survived. What is interesting to notice, when the acute liver injury did not progress on plasma exchange, we had 93% survival. So we need to catch them early and do Plex so that we have a good survival. Whereas when the patient progressed to acute liver failure, the survival was not different from another acute liver failure, which eventually was about 42%. Next slide. So I'd like to conclude with the last two slides. So patients coming late who had acute liver failure on presentation had relatively poor outcome. Therefore, it is important to catch patient early. And majority of the patients did not have any underlying psychiatric or comorbid illnesses. So these are patients who, if we get them back on track, they could potentially go back to a normal life. Next slide. And we did salvage a significant proportion of patients from both centers with plasma exchange, and patients who had satisfied Kochi and King's College criteria, which are all almost death sentence otherwise. And patients who had Thai contraindications at the outset did perform poorly compared to a patient who did not have. And we were able to salvage a significant proportion of acute liver failure, which is a very fatal condition, which is a success story of low volume plasma exchange. And when acute liver injury did not progress with plasma exchange, these patients did very well with plasma exchange. Next slide. Thank you.
Thank you, Dr. Santosh, for your presentation.